background someone. Everyone please mute yourself except me and Varshali to start with.
Recording in progress.
Okay, so shall we start, Dr. Varshali?
Yes, Varsha, go ahead.
Yeah. So I welcome you all on behalf of Society for Study of Pain Pune for this online webinar. This is the part of series of webinar we conduct every month since COVID times. And this time the theme is pelvic pain. Let's unresolve the mystery of pelvic pain. And our esteemed speakers are here. I welcome them, Dr. Lakshmi, Dr. Madhuri Lokapur, and Dr. Poonam Gandhi. And the moderator for today's session is Dr. Priya. And I would like to invite Dr. Varshali, President of Society for Study of Pain Pune, to start the session.
Thank you, Varsha. Yeah, on the behalf of Society for Study of Pain Pune, I welcome you all. Can everyone mute themselves, please?
Yeah, I muted her.
Yeah, thank you. So I welcome you all. So this is much awaited and much thought choice of topic, pelvic pain, which is hardly discussed anytime in any of the webinar, very rarely discussed. So we are looking forward with the inputs from very eminent speakers, Vas Madam, Lokapur Madam, and one of the physiotherapists, Poonam Gandhi. Yeah, so I welcome Madam and Dr. Poonam. We'll start immediately without wasting much time. We have our viewership on Zoom as well as on YouTube and Facebook. So if the people are not able to join on Zoom, they can very well watch on YouTube as well as Facebook. And we will be recording this session, which we will be sharing on the groups. Yeah, so let's start. Yeah, Dr. Priya, you can go ahead.
Good evening, everyone. I welcome you all.
Priya, let me introduce you.
Yes.
So, Dr. Priya Rathi, she is our dynamic budding pain physician from Pune Pain Society. She is the director of chronic pain services at Sigma Spine and Pain Clinic, Asian Ortho Spine Clinic, consultant pain specialist at Sancheti Hospital and Golden Care Hospital. She has got 2 international publications to her credit, and she is the fellow of Indian Academy of Pain Medicine. So I invite Priya to start this session.
Thank you, Dr. Varsha, for the kind introduction. So good evening, everyone. I welcome you all for this webinar on chronic pelvic pain. Chronic pelvic pain is very less talked about condition, even though it is very complex one. People are not ready to visit doctors because they consider themselves as if it is normal condition because they have been suffering since adolescence. So pelvic viscera, because of the anatomical congestion in the pelvis by gynec organs, uterus and ovaries, because of the ureters, because of kidneys, and also the gastrointestinal system. It is not the armamentarium of single specialty. Gynecologist, it is being treated by gynecologists also. It is being treated by gastrointestinal surgeons also. It is being treated by urologists also. So there is no fixed protocol which is being laid down to treatment of chronic pelvic pain. So we as a pain physician will learn today from experts in pain medicine about how we manage chronic pelvic pain. So today we have expert pain specialists who have reshaped the landscape of chronic pelvic pain management. I take pride in introducing our first speaker, my mentor, Dr. Lakshmi ma'am, who has not only dedicated herself to alleviating the sufferings of the patients, but also revolutionized the treatment through her protocols. Her protocols are being unique in the way that they have not been from the textbook only, but it is from a lot of research and clinical expertise. Let us congratulate ma'am for a recent award which she has received at Bangalore Medical College as Distinguished Alum of Bangalore Medical College, and it is being given to those who have been useful to the society professionally and as a personal individual. Congratulations, ma'am, from the Society of Study of Pain, Pune. Ma'am is director of Ashirwad Institute of Pain Management and Research. Ma'am is honorary consultant in pain medicine at KM Hospital and St. GS Medical College and National Burn Center, Airoli. She has developed new etiopathogenesis and effective treatment regime for CRPS that reverses not only pain but also disability in CRPS. She has proposed new concept of neuropathy to explain motor neuropathy, a vital component of neuropathic pain. She has developed ketamine-based protocol for burns pain. Ma'am has proposed and developed curriculum for fellowship in chronic pain medicine to MUHS. Ma'am received Best Researcher Award in 2015 at International Conference on Recent Advance in Pain, ICRA. And ma'am holds 100 international publications in pain medicine and has contributed 10 chapters in textbooks. So I welcome ma'am for sharing the views on topic silent discomfort, navigating the pelvic pain in men.
Thank you, Priya, for that extravagant introduction. And I must congratulate Pune Society of Pain for thinking of this unusual topic. Unusual, but certainly not uncommon. I see it fairly commonly, of male pelvic pain. And if you look at chronic pelvic pain, it is like 5 blind men describing an elephant. Urologists will say urothelial damage is causing the pain. We'll give Elmeron, or we'll dimethyl sulfoxide instillation, or Botox into the detrusor, prostate, etc. OBGY, Madhuri will speak about. And surgeons, the colorectal surgery and the orthopedic surgeons who do coxygectomy. Psychologists will talk about the mind, psychosomatic issues, and cognitive behavioral therapy. And pelvic physiotherapy, we are going to hear about it. They will talk about exercise modalities, activating the pelvic floor, relaxing the pelvic floor, etc. And anesthesiologists, the colorectal surgery, and anesthetists are late entrants into this pain because we inherited all these thoughts on pain. We have come up with blocks, pulse radio frequency, conventional radio frequency, if nothing works, spinal cord stimulator, sacral neuromodulation, etc. So every specialty has some thoughts about these pelvic pains. And anesthetists have simply developed interventions to address these pain generators. So there are many societies which have defined chronic pelvic pain. I'm taking the European Association one because that seems to be the least confusing. All of them have given different alphabets for different pains, but they're all talking about the same pains, really speaking. So EAU definition of chronic pelvic pain is that it's a chronic or persistent pain which has persisted for 3 months, or if it is cyclical, as in dysmenorrhea, etc., it has to be more than 6 months. Perceived in structures. Just note this. It is perceived to be in the structures related to the pelvis, either in men or women. It is associated with negative cognitive, behavioral, sexual and emotional consequences, as well as with symptoms suggestive of lower urinary tract problems, sexual problems, bowel problems, pelvic or gynecological dysfunction. So we call it primary chronic pelvic pain or chronic primary pelvic pain syndromes when we do not know what the cause is. The moment the word syndrome comes, that means it's a group of symptoms rather than a definite entity. And then the secondary chronic pelvic pain is usually because of a specific disease-associated pelvic pain, as in cancer or in infection. So the potential risk factors for pelvic pains are diet, alcohol, coffee, and hot pepper, spicy foods, etc. And in men, of course, is the delaying ejaculation, sexual abstinence, excessive sex, coitus interruptus, everything to do with sex. Then lifestyle issues. Then perineal trauma. Recently we had a young man come to us because he was doing gym, exercising, lifting weights. He slipped and he hits himself in the genitals with a dumbbell. So this is not very common, but can happen. So the current treatment recommendations are from the EAU only. The urinary problems, they avoid spicy foods, caffeine and alcohol, provide alpha-adrenergic antagonists, 4 milligram of sildenafil, or 5-alpha reductase inhibitor, that is dutasteride. Botox injection here is different from what we use, is in that they usually give it through the cystoscope transurethral into the lateral prostate lobes. They may give about 100 to 200 units. Transurethral microwave thermotherapy, extracorporeal shock wave therapy, and phytotherapeutics with anti-inflammatory action like Sernilton. So these are the urology approach to these pains. Most of the male pelvic pains, just a second, I want to get rid of some of these. Okay, all right. Sorry. Most of the male pelvic pains are associated with urinary and sexual dysfunction. When there is a palpably painful prostate, the European Association calls it primary prostatitis or prostatic pain syndrome. IASP calls it CPPPS of male. NIH classification calls it CPPS. So this is what I meant by saying they are all using all kinds of alphabets to mean the same things. So I am taking one of them, that is the European Association. Then one is from the prostate as a cause. One is bladder pain syndrome, which used to be called as interstitial cystitis or painful bladder. Then primary scrotal pain syndrome, which may not necessarily be clearly testicular or epididymal. Primary testicular, where the patient says it is from my testis. And primary epididymal pain syndrome, primary penile pain syndrome, urethral pain syndrome, and post-vasectomy scrotal pain syndrome. And apparently, it is about more than 1% of vasectomy patients will have post-vasectomy scrotal pains. One of the common things which is not mentioned in this classification and which I have found very commonly is post-varicocele surgery, coiling, etc. This becomes the cause for this chronic pelvic pain. Why is this? I'm not able to. Okay. So if in GI-related chronic pelvic pain, maybe irritable bowel syndrome, chronic primary anal pain syndrome, may be associated with urinary and sexual dysfunction, intermittent chronic primary anal pain syndrome, previously called proctalgia fugax, and pain is unrelated to defecation in these conditions. And then other things which come under chronic pelvic pain in men will be primary coccygeal pain syndromes, previously called coccydynia, and may be associated with urinary, sexual, bowel, or gynecological dysfunction. Then chronic post-surgical pain syndrome after rectal surgery, after vaginal or uterine surgery, or after cystoscopies or any procedures, urological procedures. And it persists beyond the healing process. So one of the new introductions into the classification is the pelvic floor muscle pain syndrome. It may be associated with all these symptoms like urinary, sexual, gynecological, or bowel dysfunction. It is associated with local tenderness in the perineum, overactive pelvic floor, and trigger points within the pelvic floor muscles. Myofascial trigger points may also be found in abdominal, thigh, and back muscles. As I mentioned, this is a recent introduction into the classification of the European Association, IASP, and NIH. However, this is what I started with somewhere in 2004 and 5. At Ashirwad, we believe that pelvic floor pain is not a separate entity. Here, it is a separate entity other than scrotal pain, other than penile pain, other than prostate pain, etc. As according to me, pelvic floor pain is not a separate pain, but it is present in and through all the pains, all the previously mentioned pains, right from coccyx posteriorly to the anal pains, to the urinary bladder pains, to the prostatic pains, testicular pains, and epididymis pains, particularly varicoceles. It is also the mediator of post-surgical neuropathic pain after bladder, bowel, and genitourinary system surgery. Because all neuropathic pains, according to me, are neuromyopathic pains, and pelvic visceral surgery will cause neuromyopathy of the pelvic floor. So, as far as I am concerned, the pelvic floor is the universal reflector of all pelvic pains in both men and women. This is a very bold thing to say when all the guidelines across the world are saying myofascial pain is one pain. But I'm saying that it is the root cause of all the pains and the manifestations of all these pains. But I am saying this because I have seen results come with this kind of thought process. Now let us look at the pelvic floor. So this is the pubic symphysis in front, coccyx at the back, ischial tuberosity below, ischial spines here. So this is the diamond-shaped pelvis. And you have, in the male, you have the urogenital triangle in front and anal triangle behind. So if you look at the muscles of the pelvic floor, you can see here that this is the coccyx. This is the hammock which is formed between the coccyx and the pubic arch. If you see here, there are several layers. The perineal membrane divides the superficial from the deep muscles and structures of the pelvic floor. The superficial perineal pouch lies between the perineal membrane deep and the collis fascia below. And the deep perineal pouch is deeper to the perineal membrane. So, perineal body is also known as the, I'm unable to take off this one screen. I don't know how to do this. Anyway, perineal body is known as the central tendon of the pelvis because many of the pelvic floor structures insert into it. It's a fibromuscular structure attaching to the sides of the pelvis to the istiopubic rami by the deep transverse perineal muscle. I'll be showing you the ultrasound views of this particular structure later on. So you can see here in the superficial perineal pouch, you have all these muscles, the bulbocavernosus, the ischiocavernosus here, the same things, and the superficial transverse perineal muscle and the external anal sphincter and perineal membrane below. So all these form the superficial structures. Just a second. Arjun, can you get rid of this?
Madam, we are able to see your screen completely okay. I mean, we don't have anything hindering. We can see the complete slide.
Yeah.
At our end.
Okay. Okay. All right. Thank you. I got, now I can see my screen. Otherwise, I was seeing a top bar, which was preventing me from seeing. Am I heard?
Yes, absolutely, madam. We
Okay.
can go ahead.
Yeah. Okay. So these are the muscles, and these are the diagrammatic representations of this. The deeper muscles above the perineal membrane and the superficial muscles beneath the yellow line of perineal membrane. So if you look at the superficial muscles, you have, this is the ischial tuberosity and the ramus here. This is the istiocavernosus. This is the bulbospongiosus. Deep transverse perineal muscle. This is the perineal membrane here. This is the superficial transverse muscles. And these are the deeper muscles of levator ani. If you look at it from above, the muscles from above, this is what it looks like. The piriformis muscle, the intrapelvic part of piriformis muscle here, is the most posterior structure. Then you have the coccygeus muscle. Then you have the pubococcygeus muscle here, and the iliococcygeus muscle, and the puborectalis muscle, which forms a sling around the rectum, and obturator internus muscle, quite lateral, very close to the pelvic wall. So these are the deeper muscles. The levator ani forms one of the major deep muscles, and it has all these components. And believe me, each and every one of this muscle is important when it comes to causing pain in these patients. The hammock of the pelvic floor is pierced by the two orifices of anus and urethra in the male and vagina in the female. These orifices are guarded and reinforced by sphincters to ensure continence. Urinary, prostatic, epididymal, and testicular pathologies refer to the genital triangle muscles. All these pathologies cause pain in these genital triangle muscles. Anal surgery and coccygeal issues refer the pain to the anal triangle muscles. So how did I come to these weird conclusions? Because my experience started in 2005 with a 22 years old law student from UK, daughter of doctor parents. She had severe interstitial cystitis. I'm starting with a lady's case because this is what developed my thought processes. I am going to the male pelvic pain little later. The severe interstitial cystitis she had, and she with a very contracted bladder capacity of just 50 ml after query tubercular cystitis in this girl about 5 years ago. That means when she was about 17 years, she got tubercular cystitis. After that, she had severe urinary problems. She had continuous pain in the lower abdomen, perineum, and perineum. She had urinary frequency, dysuria. It was like as if she was passing acid urine, voiding difficulties, which were worse at night. When I say voiding difficulties, she would take about 1 hour to void 30 to 40 ml of burning urine. Exhausted, she would fall into bed, sleep for 1 hour, and repeat the process once again. So this was a horrendous kind of a lifestyle she had. And she also had intermittent severe shocks in the perineum, radiating to ankles, particularly on sexual arousal. So she had been unresponsive in these last 5 years to repeated bladder dilatations and dimethyl sulfoxide instillations. She was unresponsive to tryptoma, which she was taking 25 milligrams. She was also unresponsive to pentosan polysulfate sodium or Elmiron, which she was taking. This is supposed to restore damaged, thin, leaky bladder surface of glycosan-aminoglycan layer of the bladder, which has a coating of mucus, which protects it from bacteria and irritant chemicals in urine. However, in spite of taking all these medications, she said nothing makes a difference to her. So in this girl, I had many objectives, treatment objectives. One is reduction of pain in the perineum, lower abdomen, reduction of frequency, dysuria, voiding difficulties. And how to do all this? I thought like an anesthetist, because this is in 2005 when I had just given up anesthesia. So I said, okay, I'll do a continuous caudal epidural catheter and an infusion to provide a continuous and protracted analgesia. I plan to keep it for a week. And so that my idea was I should wind down the spinal sensitization that has been sustained by constant pain of 5 years. Then I thought, okay, I'll also do a lumbar sympathetic block to see whether this pain was sympathetically maintained. And as for the urinary symptoms, honestly, I didn't know in 2005 what to do about it. I just hoped that urinary symptoms would resolve themselves once the pain went down. So this is the lumbar sympathetic block, which didn't really help her, though what I found was that she was hyperalgesic and every injection was painful to her. Then I did the caudal epidural anesthesia. Caudal catheter tip was positioned between S2, S4, in between that. This is where the bladder receives its innervation. So I started a bolus dose of 5 ml of bupivacaine, and then I started a continuous infusion. My idea was very simple. I will starve the afferent nociceptive input into the spinal sensitization, so the pain will wind itself down. So this is like a pharmacological deafferentation of the nociceptive input. So this girl, I had tunneled the catheter. This is where the catheter entered, and I tunneled it and rolled it up here. This is done to safeguard against accidental extrusion and infection. And this was connected to a pump like this, dosidiffuser pump. Once this was done, there was no touching of anything so that we could minimize infection chances. Her after this, the next day, she was very happy. Her abdominal and perineal pain came down by 80%. No urinary retention or incontinence, which was one of my fears when I did this. And she was able to sleep 6 hours continuously for the first time in 5 years. Wow, this was very good thing for her, and the patient was very happy. And after 7 days, this patient said, no way I'm taking out this catheter. I'm not going back to that state of getting up every hour to pass urine. So after discussion with her pathologist father, we deferred the removal of the catheter. We kept doing CBC every 5 days. So we retained the catheter like this for 36 days. She was so attached to that catheter because it remained to be safe. So we continued with it. But she had an atypical response to pregabalin, which manifested as leukopenia. She apparently had some tendencies like this. So we had to stop the pregabalin also. But still, she continued to be pain-free. And this is the catheter exit site at the end of 38 days. You can see how clean it is. So anyway, this patient's perspective helped me a lot in understanding what is wrong in these interstitial cystitis patients. In her, the urinary frequency, which was once in 15 minutes, it got reduced. She could hold the urine for about 2 to 3 hours, and she could hold up to 200 ml of urine. So, which was a great achievement. So some functional improvement had happened. But what she kept telling me was that, look, I still have a lot of difficulty in voiding urine, and I still have dysuria. So, it is lesser than before, but I still have to struggle to pass urine. She kept complaining about this. And so she also complained of clitoral pain. So these were two of the problems which I had to solve in her. So I kept wondering, what is this which is giving her this problem? I had developed a lot of respect for her feedback. She seemed to have some obstructive element. But what can obstruct her urine flow? Urethral sphincter, or was it a stricture? But previously she had had cystoscopies done by very senior urologists, and it had been normal. So I kept wondering, what's this going on? Is this some dynamic and paradoxical urethral obstruction to urine flow, which comes on only during voiding? If it is not there at other times, why does it come on during voiding? So then I read a lot about it, and then I realized that micturition requires a delicately regulated coordination between the detrusor.
Sorry to interrupt, ma'am.
Yeah.
We are running short of time, so we have to.
Already? Okay.
30 minutes are already over, ma'am.
Oh, really? Then in that case, I think forget about this. The point I'm trying to make is that muscular pelvic floor is very important. And what to do about this obstruction was my worry. So I very hesitantly suggested to the patient and her parents that we could maybe try dry needling. They were open to the idea. So we went on. Dry needling is a simple, extremely safe and effective intervention, which I need not explain here. So in ICS, she already had a caudal catheter in situ. So after a bolus of local anesthetic, once she was analgesic in the perineum, I did dry needling. And that worked like magic. The resistance to needle and introduction was significant in this girl. And so that determined my later Botox dose. She was jubilant the next day. She came and gave me a big hug and she said, I don't know what you did, but that has relieved me a lot. So this made me understand that in ICS, paradoxical urethral obstruction during micturition was a definite possibility. So this opened the possibility of Botox injection, which I did. Why this sphincter should be tight, I didn't know, but I said, leave that. So I did first Botox injection in pelvic floor in 2006. I did all these muscles. I'm not going into those details. It produced very good results. The urinary flow became stronger and free. Patient no longer had to strain. She was happy and she continues to be this way 17 years later. She had repeat Botox injection some 4 or 5 times, but the last injection was 2013 and she continues to be happy. She's happily married and works as a solicitor. This lady taught me that many concepts on ICS. The treatment that developed for her has benefited 25 other women and 15 men with ICS. The other problems I'm talking about are different. So the important thing here is there is a primary obstructive problem in ICS and there is a neuropathic bladder pain problem. Both have to be addressed. So referral from pelvic pain, of pain from pelvic viscera goes to the back, perineum, and the anterior abdominal wall. And also because of the viscerosomatic neurons, since I don't have time, I better not talk. The MTRPs not only cause pain, but also cause obstructive symptoms. And why does this pelvic floor go into spasm at all? Some people seem to tighten their perineum when stressed, be it performance anxiety, examination, work, or whatever. And then postural imbalances and gait influence the trunk positioning over the legs. So, this innovative therapy has stood the test of time. The patients continue to be comfortable for years. Now, what I started in 2006, I published in 2014, but now the world is waking up to the whole thing. And you have a 2013, 2019, 2018 papers which are talking about pelvic floor muscle tenderness. So the male genital problems, as I told you, all these are the ones related to the prostate, scrotum, etc., etc. Our male patient data, these are our patients who had these male genital pains. So again, I'm not going into these muscles. Our protocol is we give neuromodulator, pregabalin, and lifestyle and diet changes, caudal epidural injection, Botox injection, 100 to 200 units into all the perineal back, buttock, and thigh muscles. And then we do ultrasound-guided dry needling of the perineum and pelvic muscles. See, this is what the genitourinary triangle looks like on ultrasound. This is the cavernosus. This is the spongiosis. And there is a needle which is coming in here. This angle seems to be one of the causes of very severe pain in these men. And here is the transverse muscles. And this is the perineal body. And this is a video of Botox injection into the istiocavernosus muscle. This is an injection into the perineal body. So our Botox alone is unlikely to be fully effective because we have to keep the dose low. Otherwise, you can go for incontinence. So we always follow it up with 4 to 5 sessions of ultrasound-guided dry needling. Patients are taught certain pelvic relaxation exercises because the present day pelvic exercises focus on strengthening. What these people need is not strengthening, but relaxation. And they are also sent for counseling, CBT, etc. So why innovative therapies develop? There has to be a paradigm shift in the understanding of pathophysiology that suggests a whole new set of pain generators. Only then you have something to treat. Otherwise, we keep on rehashing the same things again and again and again ad nauseum. Chronic pelvic pain in men is one condition that has remained refractory to most treatments. In 2004, I found that most of the treatments based on present hypothesis were largely ineffective. So I started looking at my pelvic pain patients without any preconceived ideas. And I wanted to give them a treatment from their perspective rather than thrust available treatments on them. So to sum up, I would like to quote my first patient's father. When I was hesitantly asking him, can I do this needling, perineal needling for her? He said, Doctor, it is not as if conventional treatments have helped my daughter. At least today I am seeing my daughter smile in the morning instead of being exhausted after your unconventional treatment. I don't care how unconventional the treatment is if it produces results. So that has been my dictum for all the years from 2004 till now. So thank you very much. And I'm sorry that I lost count of time. My apologies. Thank you.
Thank you, ma'am, for giving us insight in detail anatomy, pathology, and different treatment modalities. So there is one question for you, ma'am.
Yeah. Yes.
Yes, ma'am. Just a minute. What is the dose of Botox in each muscle of pelvic floor?
See, you have to know how tight this muscle is. You have to know how that muscle works in this particular condition. So there is no fixed, protocol. When I do the needling, I get to see how tight the muscles are. And then I decide how much I will give. So I cannot really give you an answer because it varies from patient to patient. If you were to ask me for, piriformis or something, I can say maybe I'll give 15 or 20 or 25. But when it comes to these small muscles in the perineum, it is difficult to give you a number. Especially, let us say, istiocavernosus in men is responsible for erection. If you give too big a dose, erection becomes a problem. The pain is down, but the erection is not there. That's going to be a disastrous thing. So there are many considerations. So I would say if somebody wishes to learn how much dose to give, they have to first come, maybe work with me and see how the muscles feel on dry needling. And then I can guide them. The people who work with me know And Priya, I don't think we have seen too many male pelvic pains when you were there. Somehow an andrologist has discovered me in the recent year, and I have been seeing so many. They are literally coming out of the woodwork. I didn't know that there were so many pains. These, by the way, all pains are in these people. The scrotal pains are all because of the dartos muscle. And so I don't know, that slide went missing in that. So the scrotal pains are easily reversible. And again, there I can tell you the dose of Botox, maybe about 15 or 20 Botox in different places of the scrotum.
Thank you, ma'am. Hope this solves the question of Anmol. We will shift to next speaker, and if time allots, we'll take few more questions again. So, Dr. Varsha. So, our next speaker is Dr. Madhuri Lokapur. I'm truly honored to welcome ma'am. Dr. Madhuri Lokapur ma'am is one of the first pain physician in Pune, and ma'am has laid down the path for many of young pain physicians like me. Ma'am is pain management and palliative care consultant at MJM Hospital Pune, Jehangir Hospital Pune, and Ruby Hall Clinic. She has served as President of Indian Society for Study of Pain in 2021. She is founder president of Society for Study of Pain Pune. She has authored Handbook of Pain Management and Palliative Care and has been invited as faculty in various national and international conferences. Ma'am received Susan Raj Award in year 2013 at Kolkata, India. So today ma'am will be sharing her experience on the topic pelvic puzzle, unraveling the mystery of pelvic pain in women. Welcome, ma'am.
Thank you very much, Dr. Varsha, Dr. Varshali, our dynamic president, and Dr. Priya Rathi for inviting me as a faculty for this symposium, along with Lakshmi, who has done a lot of work in this field in a very innovative manner. Actually, I was not very sure because the topics given to us were that of in a male and in a female, but apart from the genital problems, most of the conditions would remain the same for both sexes. So I was not sure how much weightage would be given by Lakshmi on all these. So let me just start with the definition. The chronic pelvic pain is defined as a pelvic pain occurring for at least 6 months with sufficient intensity to interrupt normal activities of daily life and requiring medical or surgical treatment. So, chronic pelvic pain, which occurs in relation to the menstrual cycle, is called as a chronic cyclic pelvic pain. So today we are not going to go into semantics and try to differentiate between all this, but as I proceed, we will find that there are different types of pain which we can differentiate, and I would like to emphasize on evaluate various painful syndromes, and then if you can find something to pinpoint the cause of the pain, then it is much easier to treat these pains. So not all chronic pelvic pains are cyclical, and not all cyclical pains could be pathological. Like primary dysmenorrhea and Mittelschmerz or ovulation pain are the examples of physiological gynecological cyclic pains. So here the pain is familiar, short-term, managed by simple conservative methods. So these women are never seen in pain clinics. So when we talk about chronic pelvic pain, it really is a great puzzle because in the small cavity out here, you have got various systems, the urogenital, the digestive, and of course musculoskeletal, like what Lakshmi has been stressing on. So you really need to find out the pain generator so that you can target it very specifically. In the evaluation, always start with the history taking. As we always say, you have to know the location, radiation, onset, severity, take the VAS score, That will help you to find out how your treatment is progressing. As usual, the aggravating factors, the alleviating factors, effect of menstrual cycle, stress, work, exercise, and sexual experience of that woman, the context in which the pain has arisen, the social and occupational stresses as well. While taking the history, make sure that you rule out the red flags pertaining to the chronic pain, pelvic pain. Bleeding from rectum, new bowel symptoms after the age of 50 years, new pain after menopause, lumps in abdomen, irregular bleeding after the age of 40, postcoital bleeding, excessive weight loss, and suicidal ideas. These should be your red flags. If you see any of these, then further evaluation has to be done along with as per the symptoms, with the gynecologist, with the gastroenterologist pertaining to that particular specialty. Now, as we are stressing more on the female patients, the causes of pelvic pain in females, you can see that there are multiple causes because there are various structures involved, and these structures are all packed together and wrapped up with various muscles. And so they may even be causative, or sometimes you may even see them as an effect of some other pathology. Like a space occupying lesion in any one of these will cause symptoms in the other system as well. So the reproductive system we will rule out first. There are multiple painful conditions. They can arise from different parts of the reproductive system, where starting from the vaginal causes to the uterus and to the tubes and the ovaries. So endometriosis is one of the most prominent one. Then it's followed by pelvic inflammatory diseases, adenomyosis, ovarian remnant or residual ovary after hysterectomy has been done, if they have preserved the ovaries, fibroid or uterine leiomyoma, cervical stenosis or obstructive abnormalities, pelvic venous congestion syndrome. This is also coming up as major cause of pain in women, especially the postmenopausal women, pelvic adhesions and endosalpingosis. So how do we differentiate between various causes? Mind you, I'm aware that in pain clinic, the patients will have already gone to a gynecologist, but in case they come to you directly from a family physician, or if the woman is thinking that because she is postmenopausal and why this is happening, she might even be referred to you. So make sure that all the basic fundamental causes have been taken care of. So in endometriosis, there might be presence of endometrial glands, and the complaints might be dyspareunia, dyschezia, infertility, and menorrhagia. So in this case, cyclical changes might be there initially, and the gynecologist will rule it out for you. Pelvic inflammatory diseases, this age group is usually younger and sexually active women. The episodes of acute and chronic infection might be there in the history. And because of scarring, pelvic tissue damage, and adhesions, nerve entrapment will also add to the pain. So you might have a mixed picture, not just that of an infectious one, but also an inflammatory and neuropathic component might come into this. Adenomyosis is that sometimes there is presence of endometrial glands within the myometrium of the uterus. So this pain could be cyclical or non-cyclical. There might be menorrhagia, and this diagnosis can be made on ultrasound or MRI. Leiomyoma, of course, there might be history of bleeding also, and usually the gynecologist will take care of this and the ovarian remnant complaint also. Pelvic venous congestion syndrome. Now this, I have seen one case and it is pretty vivid because you just can't find anything else. Even when the MRI has been done, you can't really, unless you're looking for it, you may not find, because the radiologist may not be aware that he has to look for certain of these things. So the complaints are very vague. There is a vague pelvic pain, dyspareunia, exacerbation after prolonged period of standing. So just like varicosities in the legs might give rise to this dull aching pain in the calves, it is the same in the pelvis. And there, the venograms might give you the answer. So always keep this in the back of your mind. Once we have decided that it has nothing to do with the reproductive system, it is a non-cyclic CPP, then we start looking at the other systems. Interstitial cystitis is very common. Actually, many a time as interventional pain physicians, the gynecologist or the urologist will refer patients to you for interventional MIPSs just for this condition. So chronic recurrent urinary tract infections again can cause this. Pelvic floor dysfunction, which is very, very important. And the speaker before me has already mentioned it. And the speaker after me is actually an expert. So I leave it to her to explain more about this. Urolithiasis can also cause pain, where it would be more of an acute or chronic kind. Chronic urethral syndrome, of course, people get pain at urethra, especially after micturition. In interstitial cystitis, there is complaint about frequency, dysuria, urgency, nocturia, and chronic pelvic pain. This pain will exacerbate sometimes during menstrual cycle and confuse you. But you have to keep in mind that this has nothing to do with menstrual cycle, and it can come during the month long whenever the patient gets down with it. Inflammatory bowel disease of the GI system again is another Yorker. I mean, because this disease of inflammatory bowel disease and irritable bowel syndrome both sometimes affect and they appear as chronic pelvic pain. Colitis is another one. Chronic constipation itself can give rise to a vague, dull, aching sort of a pain in the lower down in the pelvis, and chronic intermittent bowel obstruction, especially in cancer patients. So you have to bear this in mind when dealing with any malignancies, especially that of the lower GI tract. Now, how to differentiate between inflammatory bowel disease and irritable bowel syndrome? Irritable bowel syndrome is not a disease. It is just a condition which is affecting the function and behavior of the intestines. So you have the abdominal or pelvic cramps, pain, bloating, gas, mucus in the stool. The diarrhea or constipation, it will keep changing. The exact cause is not known. But many times, stress can lead to IBS, hypersensitivity to various food substances, even alteration of fecal bacterial flora. Like if somebody has got some kind of an infection, diarrhea, the fecal bacterial flora does change and it can give rise to irritable bowel syndrome. As against this, inflammatory bowel disease is a proven disease, and ulcerative colitis and Crohn's disease fall under this heading. So usually you will have positive inflammatory markers, the endoscopy, biopsy, they will all prove this diagnosis. In that case, then the case will be referred to a gastroenterologist. But you have to be very sure with the irritable bowel syndrome, because it doesn't have the diagnostic criteria is not as specific as inflammatory bowel. In IBS, you could actually have a normal endoscopy, and so these patients might come to you. Lakshmi has spoken at length about various musculatures and various problems. So you have got various musculoskeletal problems, especially in neuropathies regarding pudendal nerve, ilioinguinal nerve, genitofemoral, or iliohypogastric nerve. So during the course of these nerves, anywhere they get any irritation or constriction, you are going to have some kind of a neuropathic pelvic pain. Now, pudendal neuralgia is something I would like to talk more about. As per the Nantes criteria, the patient should fulfill all 5 essential criteria. Pain in the anatomic territory of the pudendal nerve. It should be worsened by sitting or cycling. The patient is not woken at night by the pain, because night pains are precisely known to be of malignant variety. So this should not happen there. No objective sensory loss should be there on clinical examination, and positive, the crux will come when the diagnostic pudendal nerve block will come positive. As pudendal nerve is serving from S2 to S4, it supplies sensory innervation to external genitalia in both the sexes and the skin around the anus, anal canal, and the perineum. It supplies various pelvic muscles, the external urethral sphincter and the external anal sphincter. Autonomic supply is carried by the sympathetic nerve fibers to the skin of S2 to S4 dermatomal region. And hence, the pudendal nerve, if it gets compressed, then it can lead to various presentations. It can get compressed at various levels at ischial spine, sacrospinous and sacrotuberous ligaments, or Alcock's canal. So this is one very important differential diagnosis a pain physician should always bear in mind, provided all other systems have been relegated. So the treatment of this should be the muscle relaxants, analgesics, anticonvulsants, physiotherapy, pudendal nerve minimally invasive procedures, and finally, if nothing works and the proven constriction is there, then surgically it can be decompressed. Another pain syndrome which you have is gluteal pain syndrome. Now, this is defined as pain or numbness in the buttock, hip, and the posterior thigh with radiation or radicular pain in the sciatic nerve distribution. It has to be non-discogenic, a sciatic nerve disorder, the nerve entrapment in the deep gluteal space, and the most common sites of entrapment could be piriformis, sciatic foramen, ischial tunnel, and any of these. So, under gluteal pain syndrome, there is a plethora of different conditions. So, there might be some overlapping symptoms. So, there might be pain in either of these areas which I have already mentioned. There might be tingling, numbness, or paresthesias, and severe night pain with disturbed sleep could be there. So, the differential diagnosis, when we look at these musculoskeletal pains, you will find that in the reactive hamstring tendon pain, the pain will be more on uphill running, deadlifts, picking up boxes, and other flexion activity, which feels like person is sitting on a boggy moss. Non-discogenic sciatic nerve impairment, you have a typical radicular pain going straight down the leg with anything which puts stress on the nerve. Pudendal nerve entrapment will have increased time on the patient will give history of biking or sitting on a saddle, horse riding, and in a very typical history, when patient is sitting on the toilet seat, it relieves the pressure on the pudendal nerve, so patient might get some relief at that time. Ischiofemoral impingement, lumbar facet pain, sacroiliac joint pain. So all these pains, they have got their own specific test, and therefore you can rule them out at that same time. Ischiofemoral impingement, again, this is more seen with people who have got their THR or any surgery which has been done on hip region. So from the history itself, we can rule out crampy, non-cyclical, so inflammatory bowel, hot burning electric shock like nerve entrapment, pain is fluctuating with menstrual cycle, you could have adenomyosis or endometriosis. Non-cyclic pain could be, everything which I have talked about before. Pain with urge to void is interstitial cystitis or urethral syndrome. Postcoital bleeding, most likely to be a malignant origin of cervical cancer. Postmenopausal bleeding, endometrial cancer. Postmenopausal onset of pain, always remember the red flag. It is a red flag. Prior abdominal surgery or infection, again, adhesions, ovarian remnants. Unexplained weight loss, again think about malignancy. Physical examination is usually done by the gynecologist or a surgeon, so I won't go too much into the details of this. So in the diagnostic testing, you would have, if there is hematuria, test for all these interstitial cystitis or malignancy, mass, cyst, ultrasonography, seen on ultrasonography, CT, MRI, then think about malignancy, biopsies. Laparoscopy is advised in endometriosis, adhesions, or malignancy. One of the most important causes could be patients with CPP are often anxious and depressed. They might have problems related to marital relationships, sexual relationships, their social interactions, or occupational lives. So if there are any psychiatric comorbidities, if the patient is not forthcoming, do ask them specifically about this when it comes to CPP. Sexual abuse at any stage in life can initiate a cascade of events and reactions. So these individuals would be more vulnerable to development of chronic pelvic pain. And therefore, you would need to have counseling session for these patients, especially if you can't find any organic cause. Always be very gentle with them and ask the history in depth. Pap smear for women with chronic pelvic pain is a must, because whatever can be avoided, infectious, you must look for it. So even though they may have undergone pap smear, say 2 years ago, 3 years ago, whenever the patient comes to you, make sure that you go for pap. Transvaginal scan, sometimes if you really can't make out anything, then the diagnosis can be done, because maybe the patient has seen the gynecologist early in the disease, maybe that time it was not very obvious, but make sure these patients, before you do any intervention, make sure that you have some kind of a working diagnosis. MRI, of course, it may lack the sensitivity as far as endometriosis is concerned, but it is very useful to rule out any other sinister causes. Laparoscopy, of course, I mean, this is what a surgeon, a gynecologist might decide and go for it. Always try to screen the patients, especially women over the age of 50 years, or if any of those earlier red flags you have seen, then CA125 is a test to go for, and it is very, very essential to rule out any of these causes. So how do you manage the pain? So if you have found any particular cause which pertains to the various system, send the patient back to them. However, as a last resort, people are come to the pain clinics, which is a great misconception, because it should not be the last resort. People keep giving them all sorts of medical pills. They all keep giving them different treatment therapies. However, in a multidisciplinary pain clinic, we combine patient education, medication, CBT, physiotherapy, along with targeted interventional treatment, so that the recovery period is greatly cut short. Medicines, you can use different types of combinations for these patients depending upon what the etiology is. If there is a neuropathic element, you will also use antidepressants, gabapentins, pregabalins, all these host of drugs. I mean, it's a different topic altogether. Opioids, I would go very easy, because internationally, opioids in CPP, it is controversial. Physiotherapy, my next speaker would be talking in depth. So I will go very briefly about some interventions which we are carrying out in this particular problem. So superior hypogastric plexus is supplying afferents to the viscera from lower abdomen to from the distal part of the colon to the pelvis. So block will cause reduction in pain resulting from malignancy, especially in these organs, but even local anesthetic and steroid blocks do give very long-term relief. So definitely we should be trying. Now, there are various approaches. I'm not really going to go into the depth of how to do them, but they can be done in prone position. They can be done in anteriorly in a supine position. So various blocks, various things have been done. I always do all my sympathetic blocks under CT guidance. So I usually go with that. So here you are targeting the area between L5 and S1, and you can go anteriorly under CT scan guidance very easily. Using 22 gauge needles hasn't caused any problem so far in the practice. Ganglion impar is another one, because this is the last ganglion and this is a single ganglion in the sacrococcygeal region, and block will innervate. A block will cause relief of pain arising from perineum, distal rectum, anus, distal urethra, vulva, and distal third of the vagina. So these are various conditions for which ganglion impar block can be used. Again, like I said, most of my slides show blocks which are done under CT guidance, because that is what I prefer. And I find it to be extremely reassuring, because I know exactly where I am going and what I am doing in these circumstances, especially in patients with cancer, where the anatomy might be disturbed. See, the pudendal nerve block has been done using sonography. People have done it without using any guidance, but transvaginally. I think in today's times, when we have got all these guidance available, then we must do it under some guidance. And having a precise location will always help us with for outcomes. In the end, I would like to say that the causes of chronic pelvic pain are multiple, whether they are cyclical or non-cyclical, and it needs proper assessment and evaluation of the patient to arrive at the diagnosis and employ corrective measures. The management has to be multidisciplinary. Before signing off, I would like to remind all our viewers that the 30th National Conference of Indian Society for Study of Pain is going to be in Pune, held by Society for Study of Pain, Pune. The dates, please mark them in your calendar from 2nd of February to 4th, and I hope to see each and every one of you at the conference. Thank you very much. I hope I was within time.
Yes, ma'am. Thank you, ma'am, for giving us insight in different causes of pelvic pain in females. Also, role of history taking and various interventions which can be done in chronic pelvic pain patients. Thank you, ma'am. There is one question. Dr. Ravi Kumar is asking why malignancy pain occurs at night.
See, malignancy, it's not just at night. It can occur all throughout the day and night. So usually whenever you suspect night pains are there, you must suspect malignancy, because most of the musculoskeletal pains, like say back pain or something, they go away when you are lying down supine and not stressing the joints or the ligaments or the muscles. They relax at night, whereas unremitting pain is a sign of malignancy usually.
Thank you, ma'am. So as with previous discussion, it is very clear that chronic pelvic pain needs multimodal treatment approach. We have learned about medications, we have learned about interventions. So no interventional or non-interventional medicinal treatment is complete without physiotherapy. So we have one such speaker who has been exclusively practicing pelvic floor rehabilitation, Dr. Poonam Gandhi. She is owner and director at Precision Physiotherapy Clinic, Pune. She is pediatric pelvic floor consultant at KEM Hospital, Pune. So welcome, Dr. Poonam.
Hello.
You're audible, Dr. Poonam.
Yeah, okay. Just 1 minute. I'm sharing my screen. Yeah.
It was visible,
visible?
but it is stopped now. You stopped sharing. Share it again, please.
Okay. Is it visible now?
Yeah, it's visible. Yeah, you can make a full screen PPT.
Is this okay?
Yeah, perfect.
Okay. Hi all. So my name is Poonam, and I'll be talking about the pelvic floor physiotherapy part. The other considerations to chronic pelvic pain have already been discussed. So we'll move on to the physiotherapy. Now, before discussing what can be done for pelvic floor pain by a physiotherapist, I would just like to tell about something that patient with chronic, specifically I see specifically females. So what a patient with chronic pelvic pain goes through. So most of the time they meet a lot of physicians, they meet a lot of specialists in the field of pelvic pain, and many of them can find causes, cannot find causes. Some of them refer them to other specialists. All of them try to find out whatever is possible to help the female. And many a times they also come with this thing from the from the specialist that pain is in your head if they are not able to find out the cause. Now, this is a common but very unfortunate saying, I would say. In that pain is in your head, the saying implies that it may not be real, it's fabricated, or it's in your mind. But this is not really true. Pain is located in your head within your brain, but when you have pain, the brain is very actively processing it. So, how your brain processes information determines the pain you experience. So, yes, your pain experience is in your head, but it is very real and it can be measured and it can be changed for the better. So, this is something that we should always try to explain out to the females who come with pelvic pain, that even if it is if somebody has said that it is in your head, it is actually real. It is not something that they fabricate, or they are going through it and not really telling what is the reason, because sometimes we miss on taking big histories and find out what may be the cause, and we miss out a lot of things because it takes a lot of time. So it may be just considered that no, you're just probably saying something, it may not be there. So this is something that we have to explain them before we start on treating them. Now, pelvic floor physiotherapy, it becomes a part of multidisciplinary management of pelvic pain. So we'll be only talking about the one part of treating the pelvic pain. Now, causes of the pain which we see before we give pelvic floor physiotherapy, the causes can be musculoskeletal, it can be nerve entrapment, or psychosocial. Now, the musculoskeletal causes sources can be the joints of the pelvis. So the SI joint, the pubic symphysis, the hip joint, the joints of the lumbar spine, lumbosacral junction, all of them can refer the pain to the pelvis. The damage to the muscles of abdominal wall because of surgery, because of scars after the surgery, of any kind of other surgeries done before, or the damage to the pelvic floor muscles can give rise to pelvic pain. Pelvic organ prolapse can give rise to pelvic pain. There can be trigger points which can be deep inside in the pelvic floor. We've already discussed the anatomy of the pelvic floor before. They can be superficial in the pelvic floor. They can be in the back muscles, the global as well as the local muscles. They can be in the deep hip joint muscles or the superficial hip joint muscles. When we talk about the nerve entrapments can occur in the scar tissue because of which the patients have because of previous surgeries. They can be in the fascia, they can be in the foramens, which may result in pain and dysfunction in the distribution of the nerve. And this pain can be localized, sharp, stabbing, aching pain, which may be exacerbated by a particular movement when we are talking about the physiotherapeutic aspect of pain. The third cause can be psychosocial. There is always an association of psychological and social issues with chronic pelvic pain. When we try to talk to the women or men regarding it in deep, we will always find out some kind of psychological and social issues which are associated. And depression and sleep disorders are consequences rather than causes of pain most of the times. So before we go on to the actual physiotherapy, it is important to understand how do we start with when we are treating a patient with pelvic pain. So the important thing is first the knowledge of the pain. Once you know about the pain, it becomes very easier to reduce it. So education is actually a therapy. How you think and process pain is directly related to how much pain you experience. So a major cause of your pain is an extra sensitive nervous system. So studies have shown that once you understand what is causing your pain, your nerves immediately begin to calm. So, a 30-minute neuroscience education on pelvic pain can actually ease down the pelvic pain. So most of them come with so many different diagnoses that they have been given. Like if they have bladder or urethra problems, they'll be told interstitial cystitis हो गया है, या फिर prostate का problem रहेगा तो chronic prostatitis है, genitals का है तो endometriosis, sex organs का है तो vaginismus, vulvodynia, uterus dyspareunia. So they come with so many words and so many things that are told to them, and and that actually increases the sensitivity of the nervous system. They are scared, like, what is exactly causing my pain? It may or may not be found out. That's why most of the time they may feel more pain than they are actually experiencing. So education regarding how you feel pain, how fear and anxiety can lead to pain, is something that they have to be given before we start on with actual therapy for them. So it may seem, but education really is a therapy. So we can help them by making jargons regarding pelvic pain. Like, we can repeat when they're at home, or like, once a day or something. Like, my pelvic pain does not mean something is wrong. My nerves are just extra sensitive. There are many things that I can do to calm down the extra sensitive nerves and ease my pain. These are some things that we can tell them to help them reduce the amount of pain that they're feeling. The next that will go on to is manual therapy that we do, and the soft tissue treatment. Now, what is manual therapy? So manual therapy is basically a passive movement technique that is applied to the pelvic floor muscles, or the pelvis, or the hip joint, or the low back, by a physical therapist, which is aiming to optimize the movement of your tissue. Now, with pelvic floor, it is important to seek out a physical therapist who assesses and treats the muscles and joints of pelvic area internally as well, along with the external treatments. So, manual therapy, along with the active exercises, is what you need to help the pelvis, hips, and low back moving. Now, coming to the soft tissue treatment. For the soft tissue treatment, again, it is important to seek out a physical therapist who is using his or her hands for the mobility and health of the muscles as well as the tissues. Now, the aim is to jumpstart the mobility and health of the soft tissues. What a lot of people do not realize is that the scar tissues, which can be there from previous surgeries, or in the pelvic floor, in the perineum area, around the hip joint, is pliable. And if it has become stiff, it can be made pliable again. So, as we said before, that scar tissue can be one of the reasons for pelvic pain. So, increasing the mobility of scar tissue is one thing that we do in our treatment session. If that comes as one of the cause for pelvic pain, so it is important for you to know that manual therapy for a patient, or for other clinicians to know that the manual therapy and soft tissue treatment do not need to hurt in order to be effective. They can be done with, it will not give pain. It may lead to discomfort, but they may not hurt as much as they are thought of. Now, we will talk about some techniques that we use in manual therapy, specifically related to the pelvic floor. First is the sweet spot technique. Now, these are the techniques which we generally use specifically to the pelvic floor muscles after assessing where is the trigger point, in which muscle, in which deep muscle, as we spoke about the muscles. So, iliococcygeus or pubococcygeus or levator ani, which muscles has trigger points and which can be released to relieve the pelvic pain. They have to be found out. So we use some techniques to reduce the pain locally, and then we tell the patient to do home exercises, which can be repeated by them with help of some instruments, or they can be done with hands if it is possible. Now, the sweet spot technique is basically a trigger point pressure application at the problem point. So in the pelvic floor, wherever you feel a taut band or a trigger band, this technique is applied. The principle that we use is Weiss-Anderson's principle, that is, using 15 seconds compression on the taut band, which may cause discomfort, but it leads to reduction of pain for some time. It may come back again if you really do not find out why the pelvic floor muscle is going into spasm. So, or why is it becoming tight? So if that is not found, it may come down again. So you will have to repeat it again and again. But if it is found out that why is the pelvic floor muscle becoming tight or has become tight, it is easier to reduce it and then strengthen the other muscles so that it doesn't become tight again and again. There is another technique, that is ischemic compression technique, where we hold the pressure on the trigger band of the trigger point for 15 to 90 seconds. So little bit more pressure for more amount of time is given. It will cause a little more discomfort than the sweet spot technique. Then there is Thiel's these two techniques are done transvaginally. Then the Thiel's technique is mainly done transrectally, which is by putting the patient into left lateral position, that is side lying, and then stroking and sweeping motion is done along the length of the muscle to release that muscle, or to release the myofascial area around that muscle. So this is done. This Thiel's technique was discovered by Dr. Thiel, and it is to be given for 5 to 6 days continuously. Then alternately for 7 to 10. This was a protocol given by him. Then alternately for 7 to 10 days till the pain actually reduces in the musculature. Then deep tissue release can be done with many equipment, like pelvic wands are available, which I'll just show you. I don't know whether it's seen. So there are some pelvic wands which are available by various companies, which can help in deep tissue release of the pelvic floor muscle, which are generally used by the physical therapist. Then there is myofascial release, which is done for the low back muscles, the hip muscles, which have become tight, or which show trigger points, or which are of high tone. And this last technique, which is visceral manipulation, is a different kind of technique. It's basically what the people who practice visceral manipulation say is that the abdominal viscera has a fascia around it. Sometimes that fascia may become tight because of some reason. It may be surgery, it may be something related to eating, how your habits are, how much stress you take, how much emotions do you have. Depending upon that, some of your organs may become the fascia around the organs become tight. So with some general as well as local listening techniques, we try to find out which organ, the fascia around which organ has become tight, and we try to release that fascia so that the pain in the pelvic floor reduces. Now, this is practiced by many institutes in US as well as UK. So there is Barrel Institute in US. There is Prague Rehabilitation School, which practices this. There are many osteopathy schools which practice this. So this is one of the technique to find out what fascia may have become tight, because of which pelvic floor has gone into a spasm, or pelvic fascia release, and fascia around cecum, has it become tight. So I'll be talking about it in regards to one patient later on. So this is one of the technique that we use during our treatment. Now, the electrotherapy modalities are that we use depending upon the assessment and need. So all of them are not used for every patient. We determine what may be required for which patient depending upon the assessment completely. So there is PF360, there is EMG biofeedback, which is used to reduce the resting tone of the muscle. There is TENS, a machine that can be used, IFT, which is used to improve blood flow around the muscle or to reduce the pain. Then there is vulvar ultrasound that we use sometimes in case of vulvodynia. And dilators, which are nowadays overused or used anyhow by the women, is something which I would like to stress. It should be either reduced, because they should be prescribed by the physical therapist, or practiced in a proper way, because otherwise people get addicted to it and then they don't wean themselves on from it. It is basically a proprioceptive way to tell the patient how much she can relax and take control of it. But overuse of dilator should not be done. It should be used only when it is necessary, or depending upon the assessment. Sometimes even cryotherapy is used to reduce the pelvic pain for a shorter term of time. It can be told to the patient to do at home to reduce the pain for on short-term basis. There is internal electrical stimulation that is used by some of the physiotherapists to improve the blood circulation and eventually to reduce the pain. Now, there are some other techniques which are used, which are, I would say, not exactly directly pertaining to pelvic pain, but they help in reduction of the patient's pain in general, because they have different causes for pain. As we spoke about psychosocial causes and other causes, these techniques will also help in reduction of pain and reduction of the stress in general. One of them is graded motor imagery for pelvic pain. This is a relatively new used technique. So it is basically a fancy word for visualization. So scientists have shown that we can actually activate the movement map by imagining or visualizing the movement, not by directly performing it, but just imagine or visualize the movement. So people in pain may not be very comfortable to move in the beginning, so they can actually visualize the movement that still leads to activation of the muscles, which can be used in the treatment plan if required, if the patient is in extreme pain, but you have to give an intervention to reduce some amount of pain. This technique has shown to reduce the pain as well as activate the muscles. These are like, brain exercises for your pelvis. So you can start with simple things and you can slowly challenge the patient with different kinds of movements with like visualizing the movement. Then there are some specific exercises, like for example, which can be stretching exercises. So they loosen up the joints and muscles of your lower back, pelvis, and hips and pelvic floor, as well as easing the nerves. They ease out the nerves. And by learning some few simple, easy stretches and range of motion exercises, you can help ease your pelvic pain or even prevent the onset of some pain. So you can tell the patient to take regular breaks during the day and do some simple few stretches of pelvis as well as pelvic movements. It may work really wonders to take control of your pelvic pain in some of the patients. Then we will be talking about aerobic exercises. Now, the research has shown that aerobic
Dr.
exercise.
Poonam,
Yeah.
sorry to interrupt. Actually, it's already 9:30, so we have to go a little fast.
Okay. Okay, yeah, I'll try and complete. So aerobic exercises basically involves a lot of brisk walking, giving to the patient. It helps to reduce stress. It helps to decrease the pain. It helps to reduce the fatigue, muscle soreness. It improves sleep, which actually is disturbed in chronic pelvic pain patients. You also need to teach them how do they sit, like how long do they sit, because postural causes can also lead increase the pelvic pain. Medication has already been spoken about. Low dose antidepressants are given. Breathing and relaxation is one of the most important thing. Now I would like to discuss one of the protocol that we follow in pelvic pain during the pelvic floor. Dr. Howard Glazer formed this protocol specifically to reduce the tone in the pelvic floor muscles. What he found out on EMG was there is increased resting tone of the pelvic floor muscle, there is increased time to relax the pelvic floor muscle after contraction, and there is muscle instability. So he developed a method to treat the pelvic pain by biofeedback protocol using surface EMG, where he told the patients to have a hold time with submaximal contraction of the pelvic muscle for 10 seconds, then relax it for 10 seconds, and the total repetitions that are done are 60 in the time span of 20 minutes. The concept is as the muscles contract as well as relax, chronic tension is broken and the muscle relaxes, and it might, because of this protocol, the pain might get worse during the first month, but after 2 to 3 months the pelvic floor muscle pain will subside. So this is one of the protocol that we generally use to treat pelvic pain. Along with that, we use a lot of relaxation and breathing techniques which are incorporated in the protocol. Now, then will be, of course, good sleep, stress management strategies, goals and pacing, and graded exposure to stress is something that we always tell, along with all the techniques that we use during the physiotherapy. Exercises we already discussed, pelvic floor exercises for relaxation, which are some stretches, simple stretches, along with Glazer's protocol and breathing. Paradoxical relaxation is basically telling them how much tension is there in the muscle they're supposed to feel. So it eventually, since they have the awareness of the tension, they can easily relax. Coordination of the pelvic floor along with breathing is something we teach them for a long term as a long-term therapy at home also, because it helps in easing the pelvic pain. And functional training is like how they can do stretches, or when they are at home or at work, how they can incorporate the breathing as well as pelvic floor relaxation is what we teach after knowing their schedule throughout the day. Stretching we already spoke about, and postural re-education if they're sitting for a long time, or if they are having a postural disturbance. So basically, the important message is, if they have a calm mind, it is like ultimate weapon against all the challenges. And the most productive thing they can do is relax through breathing as well as relaxation techniques. I'd just like to discuss two case studies before we wrap up. So there was a case of vulvar pain that we encountered, who was a 41-year-old married female. She had pain with sex. She had pain in sitting. The pain was almost like constant. It was there at night. It was disturbing her sleep, her social, personal, professional life. Everything was affected because of that. The pain she used to experience was almost 9 on 10 on VAS, and we did a pre-vulvar pain assessment questionnaire before and after the management. The management consisted of pelvic floor physiotherapy, medications by a chronic pain specialist, as well as lifestyle changes. And there was it took around 5 to 6 months, but there was a measurable difference that was seen pre and post management. Of course, we also included some visceral manipulation techniques for her, as I discussed before, that the fascia around some organs may be tight, which has to be released to reduce the amount of pelvic floor muscle that is going into spasm. And the second study was of a 29-year-old female who had pain during sex, as well as pelvic pain, sexual dysfunction, and functional lumbar scoliosis. Along with that, she was about to get married, and the pain was interfering with a lot of things that she was doing during the day. She was a physiotherapist by profession, so her management again included a lot of techniques that I discussed before, which are included in pelvic floor physiotherapy. Neurokinetic therapy is basically a way where we find out why the pelvic floor muscle is going into spasm. Is it because of some other muscle which is not is underactive or not getting activated properly, because of which the pelvic floor muscle is becoming tight or working or overworking, and we try to reduce that overworking by activating or improving the strength in another muscle. And there was some lifestyle changes related to her whole day activity as well as her gym exercises which were given. After again 5 to 6 months, the functional scoliosis became better, and there was reduced pain during sex that she told us. The last thing that I would like to say is that it's always never too late to start with pelvic pain. When you're suffering from pelvic pain, it's not uncommon to want someone to, just make the pain go away. You need to apply what you have learned about pain and your body's alarm system to your life. So the pain is very sophisticated. It's for a long time. So it never comes like, okay, yesterday 3 months and all had happened, and now I'm coming for treatment. Sometimes it's for years, 5, 6 years, 7 years. So it's not going to go from high to low on like overnight. Never it's going to happen. It will continue to diminish steadily over time. But always we have to remember that pain is a normal part of life, but living with pain is not. So thank you.
Thank you, Dr. Poonam, for such a wonderful presentation. There were a few new things which we usually do not know as a pain physician, that is visceral manipulation. Also, thanks for giving us insight into various physiotherapy techniques which you use for chronic pelvic pain. Dr. Poonam, there is one question for you. What is the role of progressive muscle relaxation exercises in chronic pelvic pain patients?
See, when you say progressive muscle relaxation, it basically means, I think it is going from simple muscle relaxation, which occurs in supine, and then you do coordination, and then you do functional training. It is almost the same what I discussed. I think that you start with supine techniques where you tell them to relax, then you coordinate it with breathing, then you go on to functional movements, and then you go to integrated stretching. I think that's what we do. The only names are different, so it's okay. Like, I mean, it makes it's basically the same. So I can give one more name, but the techniques remain the same because the muscles are the same. So it doesn't matter what you say, progressive or non-progressive. whatever your patient needs, you have to give them, along with lot of talking and you have to understand many things that may be related to pain. It cannot be just one for them. And they come with many diagnoses to us. So they are like, ye bhi hai, ye bhi hai, ye bhi hai, ye bhi hai. So they are like stressed out ki what exactly is causing my pain and how do I like relax. So, and we are going to give them one more diagnosis. Yeah, you have this muscle spasm and all. So they get more irritated. So people are just giving us big diagnosis. But you have to be very simple with them and show them things that they can do in their life and not just like big things. Like, that's how I generally do in my practice.
Thank you, Dr. Poonam. Now I request Dr. Varsha to take the webinar forward.
Yeah, I have one question, Priya, for Vas Madam. Madam, if we want to do dry needling for the pelvic floor muscles, perineal muscles, and if it's a successive, like the first instance, we can give caudal block and do under that effect. But for successive dry needling, what is the way to achieve local analgesia? So, do you apply some cream or how to go about? Because it might be very painful. That area is already very sensitive.
Madam, you're on mute.
Madam, you are.
Yeah.
The first injection in many of these people with lot of pain, I usually give them Botox and then start. Once you give Botox, the pains come down. See, it looks as if it will be a horrible pain and things like that. But people do tolerate it very well because of the effect that it produces. One is when the needle goes in, it reproduces their pain. So they identify with this procedure and they are ready to come and undergo this they are willing to come and do this. And how do I achieve analgesia for it? Some patients, I may give bilateral pudendal nerve block and then do this work. Or we also give them Lyrica before we start. You will be astonished at how much pain reduction Lyrica can produce before needling. Because if you just give them something like 50 milligram or 75 milligram of Lyrica, the pain levels go down. And then we also give them some NSAID or immediate release paracetamol or even Ultracet. Or now we are using some very innovative things like sprays, tramadol spray and ketamine spray and things like that. So we can manage to get the things done even in very nervous and tense individuals. The pain per se after Botox is not very significant.
Okay, got it, madam. Thank you so much.
One more question.
One more question is there. Do we have time, Dr. Varsha?
We can take this last one.
Dr. Ravi Kumar is asking how to know that pelvic floor muscle is tight. Generally, in external muscles, we can know by jump sign, but how to know in pelvic floor muscles?
One is you still see jump sign here as well if you're doing it under ultrasound.
Okay.
One. And number two, whenever you pass a needle into a muscle, if there is pain, it is the equivalent of a jump, actually. And a normal muscle has no pain. So wherever they say that it hurts them, that is a positive place to go to.
Okay.
Does that answer, or do you want some more elaboration?
We have some scales also to know the whether it's tight or not. But
Yes.
of course, what you said was very right. Ki, wherever there is pain, there will be a trigger, there will be a knot. There will always be pain on tenderness on palpation. There are some scales that we use.
But you do see.
Laycock scale.
See,
Yes.
all of us are trained in loss of resistance. So if you sort of do needling consciously, it is very easy to find normal and abnormal muscles. If I put a needle in a muscle, I can tell you whether that normal muscle is normal or not, which I'm sure Priya can too. And whoever is practicing needling in a even fairly regular way will be able to know an normal from an abnormal muscle. So, but that's a feeling at the tips of your fingers. And the other other feedback is from the patient saying that, look, I have pain. And when you are using ultrasound, you keep seeing these twitches. You can visualize the twitches. That is the local twitch reflexes, which is pathognomonic of an abnormal muscle.
Okay, ma'am. Thank you, ma'am.
Okay, that answers almost all the questions.
Thank you.
So I would like to thank our speakers, Dr. Lakshmi, Dr. Madhuri Lokapur, and Poonam Gandhi, for giving such an immense insight for this not very commonly spoken topic. And we are very happy to have you all here for the discussion which Priya moderated. Thank you, Priya. Our SSPP team always here, ready and set before time for the session. Our technical support, Mr. Rahul Chobe, Anesthesia TV, who is taking this meeting every time on 5 platforms at one go. And we have a viewership almost reaching to 1,000 now. And last but not the least, our audience, without whom there will be no charm in discussion and interaction for any webinar. So thank you, everyone. Thank you, everyone. And good night.
Okay.
Thank
Will we
you.
end the session?
Thank you.
Yeah.
Thank you.
Thank you.
Bye-bye.
Night.
Thank you.